Today I'm going to be presenting on Mr. Olson. Mr. Olson is a 31-year-old Caucasian male who presents with right hand pain. Patient stated he injured his hand by slamming it in the car door Sunday morning approximately at 10 a.m. and it's been roughly 24 hours. The pain has been steady since the incident and describes it as a sharp stabbing pain. Movement of the hand makes the pain increase from a 4 to an 8 out of 10 and has been constant from the time of the incident. Patient states that he has tried icing and taking 200 milligrams of Advil without relief. Mr. Olson noticed some redness and swelling in his middle finger and that there is a blood blister forming under his fingernail of that same finger. Mr. Olson denies any use of drugs or alcohol prior to the incident. Medications, patient stated he has taken 200 milligrams every 6 hours as needed, and he's also on an omega supplement, and he's got allergies to penicillin. It was a mild rash resulting on his left arm. There's no pertinent family or social history. In reviewing, I spoke with Mr. Olson and he said he just had some red bruising on the blood blister under his fingernail. Patient denies pain anywhere else in his upper extremity, right extremity, and patient denies numbness or tingling of the right hand. His vitals were within normal limits. Upon physical exam, on the musculoskeletal, I examined the patient's right elbow, and the patient had good range of motion and was all within normal limits. Bilateral strength was 5 out of 5 in the elbow movements. Upon examination of the patient's right hand, upon palpation of the third proximal phalanx was painful to palpation. Patient denied any pain to other digits or throughout the rest of his right hand. Range of motion was normal when compared to the left, and I did note some weakness on the right hand when we were doing the grip strength, and there was a 4 out of 5, and primarily due to pain. Strength was 5 out of 5 on abduction and adduction of the fingers. Patient's right hand was pink, warm, and dry with arrhythmia around the third phalanx. Nail bed on the third phalanx on the right hand had a sublingual hematoma. Skin texture was smooth and turgor was elastic without tenting and immediate recoil on the dorsal surface of the hands. Patient was able to feel light touch and denies any numbness or tingling on his right hand. Imaging did reveal that the patient had a closed fracture of his third distal phalanx of the right hand. Assessment and plan to immobilize the patient's finger with a splint. Discuss the importance of the keeping it immobilized over the next 4 weeks and keeping that splint clean. For patient, and also instructed him to increase his dose of Advil to 800 milligrams every 6 hours as needed, and not to exceed a dose of 3,200 milligrams per day and not to exceed 5 days. Patient also educated the patient that he needs to take Advil with food. Patient stated that he agreed to the treatment and understood if it wasn't improving over the next week that he would come back in to get reassessed. In summary, Mr. Olson is a 31-year-old male who slammed his right hand in the car door approximately 24 hours ago. X-ray revealed a fracture of his third distal phalanx to the right hand, immobilized the joint above and below the finger with a splint. Patient will continue to take Advil as needed, not to exceed 5 days and not to exceed 3,200 milligrams per day, and will follow up with the patient in 4 weeks. Do you have any additional thoughts about the treatment of this patient?